So chapter 56 in your book is the musculoskeletal system for children. And so we're going to look at many different things that can possibly happen. Some of these are just random. We don't really know why. Other reasons could be genetic, okay? So think about all the things your muscles do. So when we think of musculoskeletal, do we think about oxygenation? Probably not always, but how do we breathe? What do we use? Muscles, right. So if your muscles don't function properly, do you think you're going to have adequate O2 going into your body? Not always. It depends on what muscles they're affecting. So, sometimes you don't think about that. Then we think about mobility issues, okay? We also have to consider potential infections that could occur. So we have 2 pages of student learning outcomes. This describes all the different things we're going to talk about today. Actually, 3. So adult versus pediatric. So we have the fontanelles. So as an adult, ideally, all of our fontanelles have closed, our sutures have come together and adhered. But in smaller children up till 2 to 3, those fontanelles, those sutures are still forming and closing up those fontanelles. Long bone growth continues till about the age of 20. Girls usually kind of level off with their heights around 16. Boys can grow even sometimes up to 22. So it just depends. And then, of course, not everybody falls into those categories. You can have a girl still have a growth spurt after the age of 16. So those long bones are very porous and less dense. So they're able to bend, buckle, or break from just simple falls, okay? A lot of people have trampolines. Who has trampolines or had one when you were a kid? Okay, I have a trampoline in my backyard, and I have a 5-year-old. When she was about 2 or 3, she would want to get on the trampoline and jump. And I would let her, but I wouldn't let her siblings jump with her. And I would kind of have them sit because that would help decrease the bounciness. Because trampolines are one of the top reasons kids have fractures in their legs as small children. Just think about that impact, okay? And think about when you're jumping on trampoline. Are you always real steady? No, sometimes you fall off, okay? And so you have to think about those things. Of course, when you're a kid, you're like, hey, I'm going to jump on the trampoline. So the functional difference. So when the baby is born, their spine is convex. As a toddler, it's concave. And then think about growing pains, okay? Most kiddos experience growing pains. So a lot of times when they say, oh, my leg hurts, it probably does hurt because it's growing. Or my arms hurt, it's because they're growing. So we're going to look at how the bone formation occurs. So the ossification process begins in a child as an embryo and continues until the range of about 18 to 21. The diaphysis is the shaft-like portion of the bone. That is the major hard portion of the bone. So that's your middle section there that you'll see. The epiphysis are the ends of the bone. So those kind of bony prominence that you see that bulge out. So these continue to layer on cartilage over time. The subchondral bone and the sponge-like calculus bone, that's where you're going to see these cartilage continues to grow. And that's what kind of helps keep that bone on bone from rubbing. Between the epiphysis and the diaphysis is the physis or the physis, either one, however you want to say it, or the growth plate, which allows the longitudinal growth during childhood. Okay, the periosteum is the membrane that covers the bone, which contains the blood vessels for nourishment of the bone. So again, when a baby's born, their posture and curvature is they're more like a C. Okay, they kind of curl up like a little C. Think about when they were in utero. They weren't all stretched out. They were kind of having to be in that fetal position. So naturally, their spine is going to maintain kind of that C curvature. Okay. Double S curve is in an older child. So that's when their upper back starts to come back and their bottom half of their back pushes out, and then they have that toddler belly. Think about that toddler belly. Every toddler has that big old belly, and it's because they have that shape of an S. So after development of the cervical and lumbar curves, with development of the motor skills, this will change as they get older. Now, scoliosis is a lateral curvature. So instead of having that normal S shape, literally, when you're looking at their back, you're going to see kind of like this. Okay, that's scoliosis. So instead of the spine being straight, like most people, they're going to have a little bit of a curvature. It can be upper, lower. It just depends. It can be mild, moderate, or severe, and we'll talk more about that. The extremities, the symmetry in length and size can be different. Think about genetics. You know, always remind moms and dads, you know, you may have a little short 18-inch baby, and then the next room has a 22-inch baby. And you got to kind of look at mom and dad. How tall is mom? How tall is dad? If you have shorter parents, you're probably going to have a smaller little newborn. If you have taller parents, they're probably going to have a little bit more length. You're going to count the fingers and toes, okay? Because sometimes there can be extras. I've had babies born with little extra thumbs or pinkies on their hands. It's just random.
Do you have like surgery to remove?
It depends. So sometimes they actually will have a bone that connects to the hand, and it looks like a normal extra pinky. Okay. Sometimes it just almost looks like a little skin tag. It may have a nail, may not have a nail. So on those that don't have the bone structure, they actually sometimes will just tie it with a suture, and it will fall off on its own, and then that spot will heal. But if there is bone that connects to the hand and the parent wants it removed, then yeah, they're going to have reconstructive surgery to have that removed. Are the extremities, do they have equal temperature? What's the bone shape? Are they bow-legged, or do their knees come in together? Not me. Their feet, do they have pigeon toes? Let me know what pigeon toes is. Where your toes kind of, you'll see people with their toes curve in and they walk with their toes in, okay? And that's actually the foot will kind of have a C shape to it, and those toes curve in, okay? Joints, how is their range of motion? Do they have hyperflexibility or immobility? And both my husband and my side of the family, we have hyperflexibility, so I'm double jointed, and all my joints is what people say double jointed, and that's just really hyperflexibility. So all my tendons are loose compared to other people. So when I was a kid, I thought it was fun to stand with my hip out of place. Now it hurts when I do it. Yes, sir.
So would that be the same as, you learned about subluxation or something today?
Yes. So it's somewhat the same, yes. So there's several different disease processes that can cause it to occur. The one we're going to talk about, we're not really going to cover it too much in this because it's pretty common. It's more common than what most people realize, but it's just that relaxation within those tendons, but it's very similar to that subluxation. Not always. I mean, they can usually, like, they can make their fingers curve, but you're not going to see that true rickety looking hand all the time, because it's just going to be when they tighten those tendons and muscles. Heat, tenderness, or swelling in those joints. Do you see that occur? Look at the muscles. Are they symmetric? What's the quality, tone, and strength? The shape and the contour. And in your book, in chapter 56, we're going to refer to the chapter a lot. That's why I had you bring your book today, because there's lots of good information in here. Just too much that I can't cover all in one class, okay? So when you look on page 15, 16, it gives you a list of questions, not just the assessment, but the list of questions that you could go in and ask the parent while you're doing that assessment, or you would ask yourself while you're assessing, okay? So one of the biggest things that is the cause of death in children is trauma or accidents, okay? Trauma is the leading death of a child or death of children older than the age of 1. Trauma also has significance to the disability in childhood and adolescent years. So these unintentional injuries is the cause of death, leading cause of death from age 1 to 19. Okay, and these are just accidents. Okay, I'm sure everyone can probably think of someone as a kid that had an accident. I knew a kid that was riding on an ATV, fell off, didn't make it. You know, that's an accident, was unintentional. Okay. The developmental stage of a child affects different aspects of injury. So what type of injury has occurred? And the physiological response to injury. How is that person responding to the injury? Unintentional injuries are the leading cause of death from kids age 1 to 19. Infants and toddlers, they have large heads, okay? So think about a little baby as they're starting to learn how to sit up. Usually what goes first? They fall head forward or head back, you know, because that head is heavy. They're more prone to head injuries from falls or motor vehicle injuries. They have a large spleen and liver, and they become more prone to direct trauma because they usually don't have a lot of adipose tissue in the abdomen. These children are small and easily thrown around in a motor vehicle accident or crash. So this is why when I teach parents at the hospital how to put the baby in the car seat, we explain to them how important it is to never add anything under the baby. Don't put a coat on the baby. That baby needs to be just in its normal clothes, strapped in the car seat, okay? And everybody's like, oh, but if I go put my baby in the car seat and it's 20 degrees below 0 outside, it's gonna be cold. Well, that's when you wrap them in a blanket. When you get them in the car, you take the blanket off, put them in the car seat, and then wrap their blanket around them. Nothing should go under that baby. No thick coat should be on that baby, and even older kids. Any child that's in any kind of car seat should not have bulky coats underneath. And the reason is because, think about that, you're not getting as tight against their body. So you have maybe 1 to 2, 3 extra inches. And when they go to move in a wreck, they're going to move more, okay? Forward, backward, side, whatever, okay? School-age children and adolescents, they have difficulty controlling their movements due to increased bone growth. The bone growth outgrows the muscle growth, okay? So the bones grow faster than the muscles do. This age group is vulnerable to dares and risk-taking. Whoever did a double dog dare? Okay. Think about when you were a kid, you would always double dog dare somebody, okay? They don't stop. Oh my gosh. My 5-year-old does not stop. She's a constant mover even in her sleep. So these kids, they don't stop. So they may have an injury, but continue playing sports or activities because it hurts, but they don't want to stop. So, you know, it can be dangerous because then they can further injure the injuries that they have. So unintentional or accidental injury, this can be a normal part of childhood. Children are very active. Their everyday activities, such as vigorous play, may lead to injury. So climbing, falling, playing, wrestling with each other. They also like to bicycle. And then, of course, now we have these little hoverboards that these kids can amazingly ride. I have not tried because otherwise I would probably die. But they have all these little things that they can ride, get on, go on. And, of course, sometimes you fall off. Children are resilient as their bones are more flexible than an adult. So they may not be as prone to fracture as they are when they're mature. So they have some flexibility, okay? Now they are a bigger risk of having long bone injuries because they are more soft, but they are going to have a little bit more give when they do fall or get hurt, okay? And these kiddos really don't calculate risks, okay? They don't think, oh, if I do this, this could happen. They're like, oh, if I do this, it's going to be really fun. You know, that's their first thought. So physical injury can be due to accidents. So it's no one's fault. So you're going to obtain a detailed history of the injury, what happened, and document it well. Do the injuries go with the story? Are they congruent? Okay. So the story parents and kiddo is telling you, do the injuries fall within the storyline, okay? So you have a 6-month-old with a broken leg after climbing out of the crib. Does that sound right? 6 months?
I was climbing out.
Okay, but typical 6 months, no, like my daughter really didn't start walking and climbing out of stuff till about 9 to 12, but still just out of the crib. That's not a big long fall, but you have a major femur fracture. That's kind of, you know, you need to dig a little further, okay?
Like if it doesn't match up, like when do you know to like accuse the parents of like?
So usually when, and we're gonna talk about this in a second, but we'll go ahead. So the big thing is, you know, you're gonna find yourself in a situation where you feel like there's abuse occurring, okay? It's gonna happen in nursing. You're gonna run across it. You as a nurse are required by law to report. You have no choice, okay? If you suspect that there is abuse occurring, you have to call CPS, okay? Because we are required by law. There's teachers, pastors, you know, nurses, doctors. There's a law. We have to. We're required to report. So does that mean I'm going to walk into the parent's room and say, okay, I don't believe this injury is the one that occurred, so I'm going to go call CPS? No, because what's going to happen? They're going to blow up, they're going to grab their kid, and they're going to leave. Can I stop them? Well, I don't want to try. I don't want to get hurt. Okay? So that's when you have to kind of play that good nurse role. Oh, you know, let me go talk to the doctor. Go out, tell the doctor your concerns, and then make that call. And a lot of times, if it's pretty significant injuries, they're going to come right then along with law enforcement because they're going to take emergent custody of that child. Okay? That doesn't always happen. Sometimes those kiddos still get sent home with mom because CPS comes in, question, even though it may not look like it adds up, they still get sent back, unfortunately.
Right. Matthew fell off a chair and he broke his arm in the middle, and they I guess just because it was an injury, they had to investigate and make sure it was an injury. So they didn't like take him away right away. They didn't even take him away. They just went to my sister's house.
Right, and someone called and did a report. And you do not have to report every injury. It's not required by law. It's just if you have a concern.
Yeah, they said that it looked almost like she could have like snapped it.
Right. So nursemaid fractures is what some people are called. So like little kids, their joints are real loose. So, you know, if you take a kid by the hand and then they start to fall, or you try to, you know, they're running out in front of a car, what are you going to do? You're going to jerk their arm, right? So then what happens? Okay, now you've made a nursemaid fracture, which is a fracture within this joint here, okay? So you go to the ER, you tell them the story, but maybe they don't feel like it's the true story. You know, maybe you jerked them up because they were acting bad or whatever, you know. So that's going to be more of a concern because of the type of fracture it is in that joint of the elbow. You see those a lot when kids are jerked and pulled, you know. But if your kid's running out in front of the car, what are you going to do? You have them by the hand, you're going to jerk them, okay? But we also see it where kids get pulled up by their hands or arms or whatever. So you're going to look at this kiddo. What is their mannerism? Are they fearful? How do they look at that parent or guardian? Because it may not always be the parent that's with them. It could be grandma, it could be aunt, it could be grandpa, it could be friend, it could be babysitter. So on examination, you're going to look at the location of the fracture. That can cause suspicion, okay? The cause of the injury, okay? So on page 1544 in your book, this just shows the clinical signs and symptoms of fractures varying depending on the location, type, and nature of the causative injury. Fractures are generally characterized by pain, abnormal positioning, edema, immobility, or decreased range of motion, ecchymosis, guarding, and crepitus. Childhood fractures most often involve the clavicle, tibia, ulnar, femur, with distal forearm fractures, the most common type. Stress fractures are most common in the tibia, fibula, metatarsals, and calcaneus. While regular exercise can encourage bone development and and be protective against fractures. So that's when you know where your typical fractures are, then you're going to know when it's atypical. Okay, so kids are going to break their wrists and their forearms. They're usually going to sometimes, to me, a femur break, depending on the story, is kind of questionable because your femur is a pretty big, thick bone. Okay, so if you know where those typical fractures occur, then you're going to know when it's an atypical spot. Okay, so they're going to do x-rays or CTs to show multiple fractures that are healed. So you're going to look at, there's 5 B's: bumps, bruises, breaks, burns, bathroom, anything that happens in the bathroom. Okay, these can be concerning things. So prevention is key. So preventable injuries is the primary cause of pediatric mortality or morbidity. So falls, motor vehicle crashes, fires, pedestrian versus motor vehicle, drowning, and firearms. That's the leading cause of death from 0 to 15. Hit by another person or object is a leading cause from 15 to 19. Poisoning is the leading cause age 1 to 4. And sports injuries are very common in school age and adolescents. So what is the nurse's role? Okay, raise awareness in your community. If you work at a pediatric clinic as a nurse, that's something you do with your patients. Create a fun little game to kind of talk to your patients and educate them when they come in. They play soccer. Okay, let's look at the things that are potentially dangerous. They get kicked in the shin. They could get kicked in the head. Think about the different things that could happen to them and kind of educate them when they come in. Yes.
Like, for example, like the parent wasn't directly like abusing the child, but like they were negligent with having like weapons or stuff. Would they still be like held accountable with like CPS and stuff?
Yep. So negligence is just as big as injury, because if you leave a 2-year-old home alone and they find a handgun and shoot their brother or themselves, well then, yeah, that parent's going to be charged. Or you left the 3-year-old home by themselves and they decided they needed something to eat and they go turn on the oven, start a fire. Yes, that's negligence on the part of the parent. So yes, they're going to, just as much as abuse, negligence is reportable too. You're going to raise awareness. So you're going to go over those admission screening questions on safety. Discharge teaching is very important. A lot of times, we want to get them out of there, so we hurriedly go in, read them the discharge instructions, and go. But if it's an injury, we need to educate on how to prevent, okay? Well-child visits, visit with children and parents about injury prevention. If you go into the school nurse role, you're going to do safety education for various age groups discussing prevention and injury, okay? So the trauma assessment, this is very important, okay? So always when someone comes in, they're carrying their kid, maybe they're not alert and oriented, their head's bobbing, what is the first thing you're going to do when they lay them on the table? Airway. We're going to make sure they're breathing, right? Because nothing else is as important than breathing, okay? We got to make sure they're breathing. Airway, breathing, and then circulation. We're going to control whatever bleeding could be there. If it's a fall, motor vehicle accident, always suspect a potential spinal cord injury. So you're going to assess for breathing, assess the airway, control bleeding, and then you're going to stabilize that head and neck, okay? Because until we rule that out, we don't want to cause further injury. So if the kid's, welling and moving their head around, they fell down 15 stairs, head over heel, they have a potential injury, correct, to their neck. So we want to make sure we stabilize that. So we're going to do a seat collar or a spine board to be placed. And do not move the child until the entire spine is stabilized. If a small child is in an accident and they're in their car seat, or an infant or a small child, you're going to leave them in that car seat, because that's just as good as a spine board if they're strapped in, okay? Because that's going to keep them from moving too much. Assess their responsiveness. Are they alert? Are they screaming? If they're screaming, what are they pulling in? Lots of air. Is it all just going into the lungs? No, it could be going into the abdomen, into their tummy. They could have gastric distension, so they could have air in their stomach. So we need to calm them down, okay? Kids, when they scream like that, tend to pull in air just like babies. A lot of time babies, mom and dad will say their baby's gassy, but if they're a crier, that's fine. Because every time they scream, they're pulling air not just into their lungs, but into their tummy. We want to control the bleeding. So children have a total body weight of 70 to 85% blood volume. Adults' volume is 60% of the body weight. So direct pressure of the wound with hand or a pressure dressing. Elevate the body part to control hemorrhage, because what happens when you raise it up? Vasodilation or vasoconstriction? Constriction, because what's going to happen to the blood flow? It's going to be harder for that heart to pump blood up, right? Because what happens when you hold your hand up in the air for a long time? Does it get tingly? And it's because you have decreased blood flow, okay? So if I have a finger cut off, I probably should put it above my heart, right? That's why we say, put it above your heart, put it above your heart. And that's because it's going to decrease that blood flow, okay? So if it's on the leg, prop it on a chair, lay them on the floor, prop it on a chair, okay? Only use a tourniquet when bleeding cannot be controlled with a pressure dressing, because then you're not only decreasing blood flow to that injury, you're decreasing blood flow to that whole extremity, okay? And so then you're putting that extremity at risk. But of course, death or lose an extremity. I would rather lose an extremity, okay? But only if you cannot get it controlled with a pressure dressing. Temperature control, a child's temperature is unstable due to large body surface area, okay? So they don't have a lot of adipose tissue. They've got a lot of thin skin. So that's going to, you know, their body temperature is going to drop quicker, okay? So when we do a head-to-toe assessment, after we do the ABCs, then it's always important to kind of do opposite of what you do with the kiddos or the adults. You want to start with the least affected area to the worst affected area, okay? Or toe to head, depending on it. You're not going to, you know, once you have kind of assessed injury, got bleeding under control, then you're going to do assessment on everything else and then go back to that injury.
What is that?
Well, okay, if you immediately go and start pushing on the injured part, what are they going to do? They're going to cry, pull back, don't touch me. So it's going to be harder then to complete the rest of your assessment, okay? So once you've got the injury controlled and everything under control and they kind of calm down, then you're going to start your full body assessment, because you need to do a full assessment to make sure there's nothing else wrong. And you're going to start either toe to head or the least injured area to the injured area, okay? And always remember those areas of, you know, don't touch areas for kids. So you leave that for last too, you know, so just because like they don't want you touching areas. So this is to find any additional injuries that you may not have been able to see initially. You're looking for deformities, edema, ecchymosis. What's ecchymosis? Bruising, okay. And other bleeding. What's a hematoma then? So it is blood under the skin, but it's kind of like causing a bump. More than just a bruise, there's a raised blood pocket, okay? Paralysis or pain. So toe to head versus head to toe may be better approach with a child in order to gain trust as you move into his or her personal space or closer to that injured area, okay? So cause and effect of immobilization, okay? So when you look in your book on page 1533, this is a really good illustration, pathophysiology of the child, okay? So causes can be disability, congenital defects, spina bifida, neuromuscular defects like muscular dystrophy, could be illness, injury. So think of integumentary burns, musculoskeletal or fractures or osteomyelitis. What's osteomyelitis? Infection of the bones. Good job. Neurologic, so traumatic brain injury, Guillain-Barré, a coma. So effects of immobilization, it delays milestones, decreases muscle strength and mass, decreases metabolism, and demineralization of the bone. Major effects are related to decreased muscle activity. So they're going to have significant loss of strength, endurance, and that muscle mass. It's going to atrophy. They're going to have bone demineralization, which can lead to osteoporosis. Okay? So the larger the portion of the body and the time period immobilized, the greater the immobility hazard. So you've got, each have a piece of paper. So in your group, Abby, whichever table you want to join, Essie and Christy, y'all can go together. I want you to write out kind of a picture pathophysiological thing, okay? So just like on here, you've got all your things that can occur. So we have a patient who's a quadriplegic, and he's been hospitalized for hypoxemia. So tell me what body systems are going to be affected, how they possibly could be affected, and then think of your nursing considerations and nursing diagnosis, okay? So however you want to do it, if you want to draw me a picture, if you want to write me a list, but in your group there, between the two or three of you, work on that for about 10 minutes, okay? So you have a quadriplegic patient, and he's hospitalized for hypoxemia. Let's say he's 15. So age makes a difference too. And you can use your picture on 1533 to kind of help you think. What body systems are affected and how they're affected. And nursing considerations as you're caring for that patient, and maybe a couple nursing diagnoses that you could come up with for this specific patient. Yeah, intervention things that you're going to do for this patient, and then even a couple nursing diagnoses.
And that'll cause your pulse to go up, no? Some calls, she'll be there all day. So pick it up every day. I took a cake to my sister.
I think that you would, I always like, she said,
And then she was like, oh, yeah, I was about to add in.
what did you do?
My two little, my niece and my cousin, they're like completely different sides of town. And I thought I was running late. I screwed up my whole morning. Put me in the bathroom.
Yeah.
Oh, yeah, I was looking up.
Oh, you were already.
So if there's low levels of the artery narrows, blood pressure too. After surgery. Yeah. Well, diagnosis is just, yeah, because they're, well, they have, oh yeah, they have
So arteries.
After cyanosis, I mean.
No oxygen?
Oh, that's what cyanosis is. So, cyanosis, neck, high blood pressure.
No, it is. So that's the first.
Hypertension. I'll be blue and hypertension. I don't know.
Is it like an Excel for the next? Huh? It's a breathing exercise.
So tired. I was listening to the morbid.
Personal breathing, yeah.
Get more oxygen to the bone.
And yeah, and it's true.
I don't know how to like. Finish it. A video of breaking down.
Oh, yeah. That's great.
Yeah, but like a real story.
This one,
That's what we did. We did like, cause we like, we can't cover everything. I like heard how this
Airways open longer and the system work completely.
and then we got down.
What about?
I was looking at the little. Oh, it's
yeah, we were gonna put cyanosis too. What cyanosis?
so I never figured sure.
Put like an arrow down.
Right in the middle of
Be in decreased circulation.
I think so, but like they all
Yeah, circulation. The body digestion.
So cyanosis is low oxygen to the whole body.
the one that was like
And for circulation.
he was a police.
For circulation.
No, that was the
Okay, gave y'all a few extra minutes. Had to go tell my husband my 5-year-old has a Google Meet at 1 for class. Today's a virtual day, so. Okay, so for our quadriplegic patient who's hospitalized, 15-year-old who's hospitalized with hypoxemia, what is our first thing we need to consider or address? Okay, so respiratory. Okay? Huh? Okay, he's gonna be short of breath because he has hypoxemia, so we're gonna address the respiratory. So if the respiratory system is being affected, what's the next system that's gonna be affected?
cardio.
Right. Okay, what's gonna happen? He's in poor circulation. How's his blood pressure gonna be? Probably gonna be high. How's his pulse gonna be? High. Okay, so his heart's having to work harder, right? Because it's thinking, okay, if I just pump the blood a little bit more, I'll have better oxygenation. Okay, so if the respiratory system's first affected, now we have the cardiac system affected. What's the next system that's probably going to be affected?
The skin.
Sedentary.
Thank you. Y'all all said it one time, and I was like, sedentary? What's sedentary? Skin. Okay. So his skin's going to be affected. He's going to have poor circulation, right? So are his hands going to be cool? How's his capillary refill going to be? Poor. Okay. So what's another system that's could probably go along with skin? Somewhat neurological, but what is going to happen to your organs? They're not going to work as well, right? They're going to slow down a little bit. So your kidneys, your gastric system, everything's going to kind of start shutting down, right? Because your respiratory system's being affected, your cardiac, so all your blood's probably being shunted here, right? Your body's trying to help your heart out, okay? Along with our cardio, what's another one that we can probably say is it being affected with the respiratory or right after? Your brain, your neuro. Okay? Because what happens when you don't have enough oxygen?
You get confused.
You get confused. Your level of conscious goes down. Those synapses aren't able to fire off as quickly, right? So you don't have that oxygen. Okay? So we've got our gastric, our skin. So see, when you look at patho, sometimes it's not always a direct line. It can be. But you have to kind of think about other systems that could potentially be affected at the same time. So what are some nursing interventions we're going to have to do for this kid? Because we've got respiratory. What are some nursing interventions?
Providers too.
Okay, O2. Okay, high Fowler's.
We recommend like the first lip breathing.
Okay, first lip, that would work.
Spirometry.
Okay. Okay. Okay, so I'm going to put that down here because we're also going to do with the skin, we'll do muscles, but musculoskeletal. Okay. Right. because why? He's in a conversation because the bell's not working as well, right? So yeah. So we're gonna do range of motion. I'm gonna put the turn to cue here, okay? Okay, probably a catheter, because is he gonna be able to get up and go to the bathroom?
No. So frequent, like 2-hour check.
Okay. And with that, I would probably say that with what, my neuro, right? He may need QTR neuro check. If his level of consciousness is decreased, right?
You might have some like, you might have some like sensory deprivation.
Right. Right. So if his sensory is down, he doesn't have as good blood flow to his extremities, what's he at risk for? DVT. But what else? If he's laying there, pressure ulcers. He's young. It doesn't matter how young or old you are. If you stay in one position for a long period of time, you're going to get pressure ulcers. Okay? Okay. So with the pressure ulcers and the DVT, what could we do as a pressure ulcers? We're going to turn Q2, reposition. What can we do for the DVT as a nursing intervention? 10 hose, SCDs, and he's probably going to be on heparin or Lovenox, right? Okay. So what's the nursing diagnosis as you can think for this guy?
Impaired gas exchange.
Right, impaired gas exchange. That's going to be your main one, right? Because if that's impaired, is everything else going to be impaired? Probably. So that's why when we do those care plans and we have you pick your top 3 nursing intervention or diagnosis considerations, you got to think, what's the worst? What's the second worst? What's the third worst? Okay, so highest priority to kind of lower. Okay? Okay, good job, guys. Make you work that brain early this morning, didn't I?
I feel like that would have helped before we learned about care plans. So we can learn with care plans.
Okay, I will make a note of that because we are trying to learn how to evolve our program to make things better for you guys. So that's a good idea. Okay, so I will let you guys take a 10-minute break so I can get my thing back on. We'll be back at 9:30, actually 9 minutes now, and we will start back up. We have another group project here in just a little bit. And there's snacks and candy. And if you didn't give me your survey yet, if you could bring it to me.
You're fine.
So I can give them to Susan so she can do her report.
My name?
Nope, nope, it's anonymous. No names, just your info. Thank you.
Thank you. That kind of made it more depressing.
Thank you.
Because you told me one of the teachers that helped me with suicide.
Thank you, sir.
One of the high school teachers committed suicide last time. And a lot of the kids committed suicide.
From here?
No, from Elkhart. He was such a nice guy. I don't know, out of everyone I saw, he was in the last one that had any of my life too. He was like the SFA guy and your welding and stuff. But thank you.
Actually, I don't need it.
Me neither. But I started, when I put them all in there, I was like, oh, I put too many Reese's eggs in there, so I took some out. Because they're my favorite.
I like this too, but I like the lemon.
Oh, yeah.
Yo lo eché anoche, dices, Raúl. I work the nurses at night. I love it. So relaxing. Yeah, if that's in. Is it true? I need to know the formula. So I know. Yeah, sulfate. Sulfate's really bad for your. One that's really good is the snake one. Well. Pero solo yeah, that's gonna be
Pues cuando no tenía yo hijos y no se me caía el pelo. I turned the 4-0 party. Anoche me era la 1 de la mañana. Que me había salido de trabajar.
Putting you on the spot. Yo soy Elisa. Yo no, ya me imagino pues, like, the entire day, like, why is it old? Le pregunté con Jaime ahí. ¿Quién? No, okay.
for those sessions.
Right.
But Janessa told me that since I'm not very much of an auditory person, but I'm really thinking that like read or write and stuff like that, or take tests, because then I'm like, okay, if I can't read this, I really know how to read. So she told me that I try
Or like from like right here.
like up into flashcards and things so I can like at least
Add color in there though.
information, so then when I'm actually like taking the test, I'm like not hindsight, I'm like, oh,
I don't think I have, all the ones that I've carried here are broken.
Yeah, I'll send it to you. That's kind of.
You have red.
Oh, give me red. Basically have 3 different parts, 4 different parts, whatever. But I will. You're welcome. Okay, so real quick, my clinical group this week. Tomorrow you'll have Shayla or Katie, I don't know, or Kate, I don't know which one, Shayla or Kate. Shayla was gonna do it, and then she said she was talking to Kate about maybe covering. So you're gonna have your normal assignment that you should have for this week. But if they get there and there's not what you need to have, she'll break it up into either newborn, postpartum, labor and delivery, whatever. I should be there Thursday or Friday, but my husband's grandmother is dying. And so if she passes, then we will have to go to my family. So lots of stressors this week. Okay, effects of immobilization on the body system. How is it affected? So we kind of talked about that in our little patho picture that you guys created for yourself or your patho list. So the muscular system. So we're going to break down each system, kind of like your picture in the book. Okay. So muscles lose strength at a rate about 3% per day. That's pretty significant if you think about it. Okay. So if you're lying there for 3 days, you lost 9% of your muscle strength. That's a lot, right? You're almost at 10%. That's a lot. Okay. So it takes several weeks or months to then regain that muscle strength. Okay, because you have to work those muscles to build that strength back up. Stretching occurs as the muscles loosen or loses tone, or as there is excess strain put on the weakened muscle. So think about foot drop. Okay, so you have this little old person or young person in the bed. How does your foot naturally lie when you're laying down? Is it flexed? It's straight down usually, right? So think about that calf muscle. It's probably going to tighten. So then whenever they go to stretch, flex, is it going to easily flex anymore if you keep it, that foot drop? No, people will lose that strength. Okay, they'll have foot drop. From the tight bed cover, so think about when you're doing your bed, loosen that feet up. Yes, sir. No. Because think about when you sleep. I don't lay in the same spot all night long. Do you? No. Most people don't. I mean, some people will stay kind of in one position for a few hours, and then you'll probably roll over to the other side or roll from your stomach to your side, however you lay. As you get older, it gets worse. You roll a lot more. And so if you were to just lay there, like if you were to just lay there for several hours, you're not going to be as strong as when you get up. But then once you get up and move. So you're thinking consistent 24 hours at a time, okay? So think about when you have that person in bed. You know, most of the time when we make our hospital beds, when I became a nurse, you still had to do the nurse corners, nice folded, crisp bed. Now so much we just kind of tuck under, But when you put that person in the bed, you want to pull those end blankets and sheets up so they can flex their feet. Because if they're tight, can they pull their feet up as easily? No. So disuse of the muscle leads to tissue breakdown and muscle atrophy. Atrophy causes decreased strength and endurance over time. So unconscious or paralyzed children, their joint mobility is restricted. So this is when contractures result. Has anybody seen anybody with contractures? Have you ever worked in a nursing home? Someone who's, bedbound, Their arms will contract up, their hands, their legs. I took care of this lady when I was a CNA while I was in LPN school, who was literally in the fetal position. And you could not move her out of the fetal position. So when we showered her, we would put her on the lift, put her on a shower bed that we had, and take her down to the shower room and shower her in there, because she could not sit up in a wheelchair because she was contractured in the fetal position. Okay. So proper positioning and passive or active range of motion exercise can help prevent contractures. And so as a nurse, this is where you can come in and educate mom and dad. You know, PT usually is going to be evaluating the patient, but they only come in once a day, right? Once every other day. So this is when you as the nurse can encourage parents to go in and do those motions. Show them how to do the passive range of motion. Pick up the leg, bend the knee back and forth, bend the foot back and forth, do circular motions. All those range of motion exercises that you can do on whatever body part is paralyzed, okay? The skeletal system. So you're going to have disruption and the osteoblastic formation or bone formation. The osteoclastic activity, which is bone resorption, that generally takes place from the daily stresses, through motion and wearing down, okay? Although the bone formation ceases during the disruption, the destruction of the bone continues. So the bone kind of breaks down and rebuilds, okay? That's how it grows and strengthens. So you're going to have demineralization, which is osteopenia. Does anybody know what osteopenia means? It's low bone mass. So your bone density is less, but then you have osteoporosis, which is where you have the brittle bones, the risk of having fractures, okay? So when they have low bone mass, then that makes them at risk for that osteoporosis or fractures. Hypercalcemia results from the increase in calcium ions that are concentrated in the blood from the demineralization. So as the bone's breaking down, calcium's being this extra calcium's being reabsorbed into the blood, so then they're going to have hypercalcemia. The cardiovascular system, so there's three main consequences that occur during an immobility. You're going to have orthostatic intolerance, increased workload on the heart, and then potential thrombus formation because of that coagulation of the blood. Lack of motion interferes with that venous return. When a child is immobile, the blood pools in the different areas, which reduces the blood flow to the trunk and the brain, because the normal tissue contraction is not contributing to the venous return. So they're at risk for DVTs. They potentially could have dependent edema, because if you're not getting good blood flow to your extremities, then what happens when your blood does flow? Your body pulls fluid from it, so that way it feels like it has nourishment, and then you're going to have dependent edema, which can then lead to skin breakdown. Because what happens when you have fluid in that tissue? It stretches, that skin gets thinner, okay? And you're going to have tissue breakdown. The total blood volume is redistributed from the lower extremities to the other parts of the body during immobility. The cardiac output and stroke volume increase, and the heart rate increases. So the respiratory system, they're going to have less O2 demand and CO2 exchange. So they're going to have shallow respirations. They're not going to be doing that big, deep breathing, okay? More effort to expand the lungs if they're in a supine position. They're going to be at risk for pneumonia, and atelectasis may develop from that shallow breathing and obstruction of the airway with thick mucus due to the impairment of normal movement of the secretions. So those secretions can't normally move like they would because they're settling. Think about gravity. Gravity does a lot for our body. And so it's settling in those bronchi, okay? And so they'll have those thick secretions. The GI system, children may have a diminished appetite, which decreases ingestion of nutrients. Their risk for aspiration is also increased, as eating and feeding may be more difficult with immobility. They could develop fecal impaction due to decreased peristalsis. So pretty much everything we talked about, you guys figured out before we looked at it. So you did good. So the renal system, the urinary system is designed to function in the upright position. Again, our body is made to stand. When a child is immobile, the peristaltic contractions of the ureters can't overcome the gravitational resistance that is created by being in a reclining position. So when they're lying down, those ureters can't naturally pull that urine all the way down into the bladder. So then it regurgitates, it goes back up, reflexes, okay? Or they can develop urinary stasis, which can then cause renal calculi, kidney stones. Their metabolism decreases due to nutritional intake because it decreases. So when you have less nutritional intake, then your metabolism slows down, okay? Protein intake is decreased, delaying healing, because when you have a wound or you have an incision, you need that extra protein to heal that affected area. The decrease in metabolism leads to a decrease in an energy level. So when you feel sluggish, then you have a poor appetite, and then you don't want to eat. So therefore, your metabolism slows down, causes your healing process to slow down. So it's kind of like dominoes falling, one right after another. Integumentary system. So we talked about skin ulcers. You're going to have breakdown due to moisture, friction, shearing, and pressure. So just a tidbit. When you have a patient, because in OB we have to think about this because we have people with epidurals. When you have an epidural, you're not always able to move your legs as well. And I've actually had moms who develop pressure ulcers on the back of their heels because the nurse didn't help them rotate their bodies, okay? So when you have a patient in your bed, you put a draw sheet under them, right? Most of the time. Please, a lot of people do not properly place draw sheets because no one has properly taught them how to do it. Huh? No wrinkles, because that's going to cause breakdown. Huh? Positioning where it's at. Your draw sheet should be from the shoulders past the butt, not across this part of your body. The draw sheets that they send you are too small. So I like to use a full flat sheet, fold it in half, because the more linen I have underneath them, the less friction that's going to occur on their skin when I pull them up in bed, okay? So I like my draw sheet to pretty much almost go from their shoulder to mid-thigh or knee, depending on how long they are, okay? So that way I can move them up and I'm not going to have their buttocks rubbing against the sheet or their shoulders, okay? So think about that. Plus, as a nurse, it gives me more leverage and weight of their body, because if I'm just trying to lift the midsection of their body, what's going to happen? Their shoulders are going to go back, their butt's going to go down, and you're going to have lots of extra weight you're not able to lift and move, okay? So utilize your draw sheets. You are going to be a nurse for a long time. Save your back, okay? A little speech. Okay. So friction can occur, shearing and pressure. So circulation in skin is reduced due to inactivity and dependent edema. So our neurosensory, we mentioned this, they're going to have excessive pressure on nerves with fluid buildup or improper body positioning. They could have foot drop. They could even have wrist drop, okay? So that's going to affect the peroneal nerve for your foot drop, your radial nerve for your wrist drop. So position changes are important. I know it's hard when you have a patient turn Q2 and you have 6 other patients that are turn Q2. It's hard, but just try to stay on top of it, okay? As a nurse, if you know your aide has a ton of turns, help her. If you only have 4 patients and one of them is only a turn, then ask your partner, Hey, let's go turn them because I know the aides have 6 turns on the other hall. Okay? You can turn your patients. If you're busy, you're having to give meds, yes, you can depend on your aides. But as a nurse, you are fully capable of doing it just as much as your aides are.
Do you document when you turn them?
Yes, I do. And the reason is because what happens if they build a pressure ulcer and the family decides they're going to sue the hospital? They look back at the medical records and there's no documentation of turning. Who's at fault? The hospital, right? Even though more than likely they're going to be found at fault even with the turns, but if you should document them when you turn them and reposition them. Very important. So this picture I added last night. It's a little bit different than the one that's on there. So it will be on when I upload my teacher slides. Because the one I found first used a little bit different terms, and I wanted to use the picture that the book uses with the correct terms. Okay. So pediatric fractures. This picture is found on page 1543 in your book. So we have different classifications and types. Okay. So a complete fracture is a transverse fracture. So straight across the bone. Okay. Break across the entire section of the bone at a right angle to the bone shaft, resulting in 2 or more fragments. Okay. An open fracture is when that bone pierces through the skin. Okay. A green stick fracture is when you have a fracture, but you don't have the separation. Think about a twig that is still a little bit green and you break it. Does it fully break in half? No, it's still broken, but it doesn't come apart. So think about that. That's why it's called a green stick fracture. It's fractured, but it fully hasn't separated. Okay. So this is caused by compression force, often seen in young children. So a spiral fracture is when you have twisting. So someone turned and that bone actually twists. Okay. Yes, sir.
There's like more than one type.
Oh yeah. Yes. Yeah. Because if you have, I mean, it can happen.
Like you can have like a green stick fracture and a comminuted.
Yeah, if you have several fractures in one bone, yeah, you could have like a green stick higher and a complete lower, you know. So a spiral fracture is where the bone actually twists a little, okay, displaced. A closed fracture is when the bone does not protrude through the skin. So you have the open fracture and a closed fracture. So you could have a green stick closed fracture because it didn't pierce through the skin. So yeah. So communicated fracture is when it's a high impact and you have the bone and you have little pieces, like it breaks up. Okay. So the simple or closed fracture is probably what you're going to see the most with kiddos. You're going to see just a line, those hairline. Have you ever heard of hairline fractures? Okay. Kids can have those. My daughter had a hairline fracture in her elbow. She actually had a nursemaid break, but it wasn't from me grabbing her arms. It was because she was climbing over a playpen with her cousins. They were playing, and she fell right on her elbow, and it caused it. Yes, sir.
What's the difference between complete and closed?
So you're going to have a complete closed fracture. Closed just means that it didn't pierce through the skin. Okay, so there's no difference. It's just it's closed, not open. Okay, that's the classification between open and closed. Okay, so a complete is where it completely has separated. Okay, so just remember, if you have a little girl that comes in, you look at the x-ray and you can actually see a separation, that's going to be a complete fracture. Okay. Yum. So, okay. My husband watches football NFL. And this last couple years, there have been some significant injuries during games, like where guys run into legs and legs like buckle. And then they like to replay it over and over and over again on the TV screen. And I'm like, please don't do that, because bones drive. I can't do bones. Okay. So this picture really grosses me out. Okay. So, signs and symptoms of a fracture. Okay. Suspect a fracture if the child refuses to walk or crawl, complains of something wrong, the infant cries continuously, there's swelling, pain, or tenderness, you have muscle rigidity, gross deformity, as we see here, or crepitus. And crepitus is that like crunchy sound or feel, okay? So fun story, my husband, when he was a kid, was outside playing and he fell and he broke both bones in his arm, okay? It was displaced, but he had on a long sleeve shirt. He comes inside and he tells his mom, Mom, my arm really hurts. Well, they were getting ready to go to the mall. He had like been outside when he was supposed to be. And she's like, David, get your jacket on, we're going to the mall. But Mom, my arm hurts really bad. You're fine, you know, because what do moms do? You know, get up, rub some dirt on it, you're okay. You know, especially nurse moms. And so she's like, you're fine, just get your jacket, we gotta go. Well, his grandpa came, he was taking him to the mall, and he's like, Grandpa, my arm really hurts. So he pulls up David's sleeve, and his arm is misshapen. And he was like, Jackie, did you look at his arm? Well, no. So they didn't go to the mall, they went to the ER. So, you know, of course his mom sometimes, because he wasn't like screaming and hollering and crying. He was just saying, Mom, my arm really hurts, okay? But that's some kids. Some kids don't react like you would expect them to react when they're injured. Now, my 5-year-old gets an itty scratch. She thinks she's dying, okay? And will not let me touch her or look at it. You know, she tells me she's hurt, but I can't touch or look at it, okay? So, it's sometimes hard to read kids, but that's why you have to look, okay? Look at those other signs and symptoms that can potentially be there. So, treatments of the fracture. Our goals are to reestablish alignment and the length of the bony fragments. Okay, so it's a reduction. Retain alignment and length, so we're going to mobilize that. We want to restore function to the injured parts and prevent further injury or deformity. We have to assess the soft tissue around it. We want to keep them NPO just in case they do have to have surgery. You're going to assess color, sensation, motion, and pulses in the distal from the injury, okay? So if you have an upper arm fracture, you want to check brachial and radial, okay? If you have a forearm fracture, you're going to check your radial, okay? Same on legs, below, whatever fracture is there. They may be splinted first and then casted later. They could have an internal or external fixation. Pins may be placed, and of course, most of the time, these kiddos are going to get an x-ray. So there's 3 types of casts. So if you look in your book on page 1518, kind of gives you a nursing care of the child with a cast, okay? On that table 56-1, and on page 1519, the care of the child and the cast at the bottom page. Okay, those two tables will kind of give you ideas of how we care for these children. So the upper extremity, short or long, can be the elbow or the wrist, okay, or the arm. So if the fracture's in this part of the arm, they may do the whole arm. If it's in the lower part of the arm, they're just going to probably do the lower part of the arm. Sometimes if it's the thumb, they have to cast the whole hand to keep that thumb immobilized. Okay, it just depends on how the fracture is and what's going on. Lower extremity, it could be a short or a long cast, so ankle or knee. Spica could be a hip, knee, or shoulder. So those are those body casts, and that's what you see on this kiddo on page 1518, is that lower body cast. So application, you're going to consider the developmental age of the child prior to application because you need to know how are you going to approach this, okay? Because you as a nurse, you're going to help cast this child. The doctor's going to do the casting, but you're going to be in there with the process. You have to gather the supplies. You're going to be in there. You may want to use a plastic doll or stuffed animal to explain the procedure to the kid, depending on how young they are. Use distraction methods, discuss pets, school activities. You're going to look for cuts, abrasions, cuts on the skin prior to application, because what can happen if you have an open wound there and you cast over it? Infection, because that's going to be a warm, moist, dark area, okay? So, you know, if you see something open, make sure you let the physician know. Avoid handling with your fingers so as not to cause indentations in the cast that could create pressure areas. So after they're casted, they're going to have to stay immobilized for just a short time till that dries. A lot of our casting material now dries really quickly. Not like the old-timey plaster casts where they wrapped and wrapped, had to sit for hours until it completely dried. Most of the stuff they use now dries within minutes, okay? The removal. Has anybody ever seen a cast removed? Yeah. It's pretty scary. It's an actual saw.
Have they changed that?
Huh?
Have they changed it?
It's still the saw. Yeah.
I have scars from it.
Well, that now they're not as sharp as they used to be. They're a little bit different. Okay. We ideally try not to go to the skin, but they're still a saw, but they are different types of blades that they use. Whether or not, if it does get close to the skin, it doesn't usually cut the skin. I've seen a few in the ER when I would go down and work, but they're scary because it's loud. Okay. You bring out the saw, kind of like, you know, coming at you.
They told me that it's pretty much impossible to cut the skin.
Right, with the new ones, yeah, it's impossible to cut the skin because the type of blade it is, and it's like it automatically stops once it hits
Does the
soft
doctor
tissue.
do that?
Huh?
Does the doctor do that?
No, the nurse cuts it off.
I was
Oh, really?
but they told me if I went to ortho, they were like, you're gonna do this.
Yeah.
Yeah.
Heidi.
When the doctor cut me,
Uh-huh.
I was like, you just cut my skin. And he goes, no, I didn't. And I'm like, yes, you did. I was like, Mom, you just cut my skin. And then he took my cast and I was bleeding. And he was just like,
Oh no, I did cut your skin.
and then my mom's like, but they didn't know English. So she's like, what can we do? And I was like, I don't know. He just cut my skin.
Oh no.
I still have scars.
So how do you assess the prior to like taking the cast off? Like, do you know if there's like an open wound, like something happened during or infection or something?
You're not gonna know until you take it off, unless they start complaining. If they start running a fever or complaining of increased pressure, pain inside underneath. But that's why we're gonna talk about what we're gonna tell the kids not to put anything down in there. You know, if it itches you, don't try to scratch it. You know, people will try all kinds of stuff. I've seen forks, you know, stick a fork down in there, scratch your skin, you know. So, you have a question? Oh, okay. Okay, so the sound of the cutter is frightening. It's very loud. They're going to be scared. They're going to afraid you're going to cut their whole arm off, not just the cast. It works actually with kind of like a vibration, so it's not really a cut. Like the spinning of a saw is kind of like a vibration back and forth. So after removal, disquaminated skin is present. So that's going to be skin that's kind of like peeling and yucky looking, okay? Because it's dead. So think about how often you slough skin off every day, right? So all that extra dead skin's going to be still stuck there. So you can tell them they can soak in a warm bath, and that sometimes will help it come off quicker. But after several days, it's going to come off, okay? But if they're insistent, say, okay, you can soak it in warm, soapy water, and it should kind of come off. But you don't want them to scrub or pull, because then you're going to cause irritation and maybe an open area, okay? The extremity usually has decreased muscle mass, and sometimes will be smaller. Like you'll have one bitty bitty arm and one big arm because the muscles have not been able to be used. So just reassure them it's going to be normal. Again, it'll, as that muscle gets that strength back and grows, it will look normal. So as a nurse, our job is to assist and then assess. So once the cast is applied to the extremity, it may continue to swell. So we're going to assess for neurovascular compromise or compartment syndrome. So we're going to assess using the 7 P's of ischemia. Okay? Pain, pallor, pulselessness, paresthesia, paralysis, pressure, and poikilothermia. Okay? And everybody's like, what's poikilothermia? That is, right, the temperature. It's your skin and temperature is going to take on the temperature of the room, basically. Okay? So poikilothermia is where it actually takes on the temperature of the outside area.
So is this, what was it, the 6 feet, 7?
7. So it's pain, pallor, which is color, pulselessness, so you want to assess the pulse, paresthesia, what's paresthesia? Tingling, right. Do they have tingling in that extremity? What would that indicate if they have tingling? Right, compression is it's decreased flow, blood flow, okay? Paralysis, pressure, and then poikilothermia, which these are going to be on another slide further down, guys, so if you don't get them all written down. So you're going to elevate the extremity to help decrease the edema. So when they have a body cast in place, it's important that the cast can be, that it's dry and it's even before you start moving them. You want to make sure it's completely dry, because again, if you cause a pressure, like a part that indents more, that's going to be a pressurized spot, and if they lie on that spot, you're going to have increased pressure. Educate. So elimination. For children with a spica cast, they may need to use a small bedpan or other container options for elimination. So a spica cast is where it's actually so it goes up above the pelvis, okay? And usually it comes down depending on how far, and then it's going to come up, but it's going to be open around that groin area, okay? So even if it's for the hip, it's going to be open in the groin so they can still go to the bathroom. Sometimes they'll even, if it's like immobilization of the hip, they may even have kind of like a bar across here to help keep it in a certain position as far as like the width of the hips. So this is the hips. So heads up here, body. This is your hips, legs. Okay? And then it's going to be open in that middle part to where they can use the bathroom. So you have to be creative, okay? They're not going to be able to go just sit on a toilet. So bedpan, boys can use a urinal, you know, if they just want to put a bucket underneath them. Whatever is going to help them be able to use the bathroom, okay? You're going to use a protective skin barrier. Plastic wraps or an absorbent pad may be used to help reduce the risk of urine burns or a heat rash, okay? If it's a small child and you do have to place a diaper somehow, you're going to make sure you keep them dry. So once they void, change them immediately. One, we don't want to cause any moisture to gather under the cast or reduce the durability of it, but then also we don't want to cause skin irritation. Transportation, specifically designed car seats and restraints may be needed to meet car safety. Bathing can be performed if the cast is kept out of the water and or covered. So probably bed baths if they have a spica cast. They have some really neat cast covers now that you can get on Amazon, you know, that goes over the arm and tapes up pretty good if it's an arm cast or a leg cast, and then they can still shower, okay? But if it's a spica cast or an upper extremity or upper chest cast, they're probably going to have a bed bath. And the parents should be taught how to observe signs and symptoms that the cast is too tight or too loose. Because if it's too loose, it's not going to work the way it's supposed to. Okay? So on page 1545 in your book, it talks about compartment syndrome. So I want you to turn your paper over that you used earlier. And as in your groups there, I want you to read about compartment syndrome. Write down what is it, what are the symptoms, what do you do for it, and anything else you can come up with. And I'll write my what. It's supposed to be on 1545. So there's a table there on 1545. And then it's and then monitor neurovascular status that talks about compartment syndrome. So what is it? What are the symptoms? What do you do for it? And anything else that you find information-wise.
So that the pressure will be decreased. So what the pressure decreases. Blood flow decreases.
Okay, guys, I'm gonna let you guys work on this for a few minutes. I've got to run over to the KSDN meeting, okay? So I should be back in just a few minutes. So work on the compartment syndrome and I'll be right back.
It decreases muscles and nerves from the. I don't know how to put it. Tengo que ir a recoger una llanta. me necesitado todo. It's not like.
Don't let it ruin your
I
whole
know.
rest of your day.
Yo le dije que iba a ir más que salgas y vas a llegar a la
¿Por qué no vas after? It's not like.
porque quiere que lo recoja luego porque si no lo van a tirar o no. Okay.
Probably.
And just like I said, pero así que me quedé I just need to work out. I was in bad mood with Mother yesterday.
I don't know. He didn't remember cuando llegaste. Did ask him about going out to you with his mom?
He told me that he wanted to, like, estaba esperando y no llegaste.
Why is it even?
Have you ever seen?
No me dijiste nada de ir a comer. He put me in a bad mood. Yeah. Like, he just put me in a bad mood. So I went to the gym again. I was just in bad mood. You already know how he is.
Scratch me, was it?
Cuando comes up with something else and he wants me to do. Se me murió Ben. My phone died.
I know. And be careful.
Yeah, red was this one.
Whenever I can't do what I plan, it really because I like to plan it and actually do it. And I can't do it.
Oh, this one. Yeah, this one. The red one. Yeah.
You don't have a regular?
I use my alarm for 7 and I try to get up. Oh my gosh. Pero es por eso las 6 de la mañana se me fresh here. So I like it really like kills me after that. Like I go back to sleep. That's whenever I like have my deep sleep body. But once I go back to sleep, more like dead and then try to wake up.
Todas están también arregladas y yo toda. We don't leave. I'll take a picture.
What else should I write about it? Check extremities. I put prevention. What? Los que tienen ahí. Sense pain. She's like, you better not. Yeah, causes of pain could be from a cast.
A fracture. Yeah, just like there's so much going on. And I feel like most of our pictures.
Samara, pues no te la get to you. Déjala de get to you ya. Hay que superarlo.
I want to get it in a tomorrow, like,
Okay. Compartment syndrome. Now I had to go over and watch them vote to see if we got our curriculum change, and we did. Doesn't affect you guys, but it affects level 1 coming in next year. Curriculum change. Instead of having like fundamentals, med-surg, OB, mental health, it's all going to be kind of transitioned together through, like, you're going to have nursing 1, nursing 2, nursing 3, nursing 4. And it kind of is more concept based. And so it's kind of what a lot of programs are going to now. And they've been working on it for a couple years before I started. and get it approved. So we're excited.
We're gonna have more classes now?
No, not you. Doesn't affect you guys at all.
So it wouldn't affect us next year either,
Nope.
like nothing.
No, your class will continue through the curriculum like we're doing now. It'll be just the level 1 coming in.
So they would have like where they wouldn't have to pass gerontology to be able to do the next one?
Right. It'll just be,
One.
yeah.
Okay.
Okay, so compartment syndrome. So you have circulation and neurovascular compromise. So you guys talked about compartment syndrome. Tell me what it is.
Decrease circulation, decrease circulation.
Okay, so you have lots of swelling, which causes circulation to come down. Okay, so what are some, you gave me some symptoms. Any other symptoms? What are they going to complain of? Numbness, tingling,
A lot of pressure.
a lot of pain, lots of pressure. Okay, so what do?
Thus,
You're going to assess it.
Release the pressure.
The physician's going to release the pressure. How do they do that?
Cut it.
They cut it open. This is literally what they do But- until that edema goes down.
so like they're just sitting there open in the operating room.
And sometimes they'll even be sent back to the floor with it open.
So imagine if they let it feel from the inside out.
No, what they'll do is once that edema has gone down, then they're going to go in and close it. So they're going to have a dressing over it. Usually it's kind of like a plastic drape that's going to stay over it because you want to keep the moisture in. You don't want to keep bacteria in, but you need to keep moisture in that part of the body. Usually it doesn't take long, a couple days, because they're going to give medicines, help reduce that swelling, and then they'll go back in and close it up. Okay, but yes, they can even go to the floor. I mean, there's even people that have open heart surgery that sometimes they don't close the chest because they have to leave it open for whatever reason, and then they'll go back in a couple days later, take them back to the OR and close it.
Is there like ways to like forcefully like stop the swelling like within minutes, or do you have to let it do it on its own?
Do they usually like put a wound vac or something on that?
Not necessarily, because it's not necessarily that you need to, you're not pulling off, you can't really pull off the fluid. It's just got to go down on its own. Okay. So y'all talked about assessment. So again, this is where your 7 Ps come in. Okay. And your 7 Ps are also on page 1545 there in that table. So you have paresthesia, pain, pressure, pallor, paralysis, pulselessness, poikilothermia. Okay? I missed the T there, sorry. And this can occur quickly. So a lot of times nowadays, they don't immediately cast things. Okay? A couple years ago, I fractured my left great toe. Okay? Like shattered the bone. Like shattered. Okay, it's a little bone. It's broken into many pieces, okay? Happened in New Mexico. Went to the ER. First, I thought I had just dislocated because it literally was like, you know, here's your normal toes. Here's my great toe. Bent to the side. So I thought, oh, maybe I just dislocated it. No, I shattered the bone. So I was like, oh my gosh, I'm going to have surgery in New Mexico. And the doctor in the ER consulted with ortho, and they're like, no. They're not going to do anything till the swelling goes down. Okay. So just like sometimes in other extremities, they're probably just going to put a brace or a splint on it till some of that swelling goes down. And then they can go in and do surgery if they have to do surgery. So yes, the treatment is a fasciotomy. Okay. So they're going to go in and actually cut through to the fascia. Okay. To help that be able to expand and open, and then hopefully reduce over time. So now we're going to talk about traction. So sometimes when you have a fracture, usually of a leg, a hip, they're going to have to be in some kind of traction. What's the traction most people kind of think of? Your older people probably don't see it as often anymore. It's called Buck's traction. We see it all the time. And that's where they have something tied around their lower leg. You've got this little pulley system. A weight hangs off the end of the bed, and it keeps that leg aligned, okay, for the hip. Don't always see it as much anymore. So you're seeing traction less frequently because sometimes healthcare cuts, immobilization and social issues, you don't want to keep them immobilized. But then also we have advancement in surgery. We're able to do surgeries now that people can actually get up and walk the next day, okay? We're not having to keep them in traction to help that heal. So the purpose is, there's three main purposes for traction, used for reduction, okay? So we're realigning the bone. We're allowing the body part to heal, so you have fatigue involved in muscles and reduced muscle spasms so that the bone can be realigned, okay? So we're helping those muscles relax. We're positioning the distal and proximal bone in the desired realignment to promote a satisfactory bone healing. You immobilize the fracture site until realignment has been achieved and sufficient healing has taken place to permit casting and splinting. So the primary purposes, again, are to realign, provide rest for extremity, prevent or improve contracture, correct joint deformity, treat dislocation, pre- and post-op positioning and alignment. Immobilization of the specific area until that casting or splinting can occur, and we're reducing that muscle fatigue and spasms. So traction and countertraction. Traction is provided by weight applied to the distal bone fragment. So you have a forward force. Countertraction is applied by the person's body weight. So you have a backward force, so that muscle's pulling. So the types of traction, the need depends on the age of the patient, the condition of the tissue, and the type and degree of the fracture displacement. Manual, which is upper extremities, so it's applied by hand during application of the cast or during closed reduction, so where they actually manually pull that bone into place. So when I fractured my toe, the doctor had to tape my great toe to my second toe to keep it aligned, and she numbed my toe. She put in lidocaine in the nerve in my toe. Well, it helped some, but I will say I yelled at her when she did it, because it hurt. So you're manually moving that bone back into place, okay? So you're probably usually going to give pain medication to your patient and maybe some Versed, so that way they don't remember it. Yes, sir.
So does this apply to like younger people?
It can. It just depends on the break. Manual replacement, it just depends on what type of break it is. So,
Like babies?
huh? Yeah. Yep, even babies. If the break is to where they can manually reduce it, they're going to do that because that's going to be more cost effective than trying to take them into surgery. Now they may sedate them a little bit before they do it, so they might take them to the OR, sedate them, and then do manual depending on the age. But like in an older teenager, older child, or adult, they're just going to give them some medicine at the bedside and do it in the room. Skin, so applied to the skin surface, so you're placing traction directly on the bones and muscles. So this is like where you actually like wrap around the leg that then the traction is applied to. Pulling it attached to the skin with adhesive material, straps, foam boots, or halters. And then you have skeletal, which is applied to the skeletal structure by a pin, wire, or tongs through the bone. So these are surgically placed. So traction of the lower extremities, there's two types. There's one type we're going to talk about, but there's several types. Bryant is the main one we're going to talk about. So it's skin traction to the leg. So this is when you have a femur fracture. It's used for children usually under the age of 3, weighing less than 35 pounds. This can be for, again, the femur fracture, hip dislocation, or if they have the developmental dysplasia of the hip. Both legs are elevated. The buttocks is actually off the bed, and the legs are at a 90-degree angle, okay, from the body, okay? The knees will be slightly bent a little bit. You don't want the leg to be completely straight. You need a little bit bend in the knee, but you're basically keeping that leg straight, those buttocks off the bed. Our nursing care is we need to know the purpose and the reason they have this done. We need to look at our skin, observe color. Are they in pain? Think of your 7 P's of ischemia. Do they feel tingling? What's the temperature? Assess the pin sites if it's and this is gonna, if they have the skeletal immobilization, you're gonna assess pin sites, clean those sites, teach the parents how to help, reposition child to upper body, clean, and then also we're gonna do pain relief. Buck traction, that's the one I'm familiar with that have used a lot in my younger years as a nurse. So it's a knee immobilization. It's a short-term immobilization, so a lot of times they'll do this if they're trying to not have to go in and do like a replacement or fixation. The leg is kept in an extended position without hip flexion. So you have a single pulley system with a traction applied to the extremity in one direction. So this is just this is just to help them be able to reposition themselves. They're the device, but this is the actual buck traction. So you have it wrapped around the leg, and it's just keeping that leg aligned straight, and you have weights on the other end of the pulley system.
Like if you classify it as a restraint.
No. It's not, doesn't fall under the restraint policy. So no. In most hospitals, if you have a fixation, even though it is somewhat of a restraining device, it's not like a restraint. It's not considered like you're restraining them.
It wouldn't be a restraint because you're not using it that way.
Right,
You
it's
could
being
use
used.
it as a restraint.
Right, you could, but it's being used as an actual, but you don't have to document like as a restraint. You don't have to have an order. So no. So Russell traction is similar, okay? But instead of having just the weight at the bottom, you also have the system that helps hold the leg up, okay? This is usually it's usually skin traction again. It's for the lower leg, and you have a sling that's under the knee. So this is used for femur fractures and lower leg fractures. So on the nursing care for your Russell traction, it's very important that you maintain the hip flexion and watch for foot drop, okay? I'm gonna make sure that they don't have the foot drop. You need to have them doing ankle pumps. So 90-90 traction. So the lower leg is in a cast. This is used for femur or tibia fracture. So they're going to cast the lower leg. There may be pins or wires in the lower femur. And this is going to be skeletal traction. The skeletal pin or wire is placed through the distal part of the femur, while the lower part of the extremity is in a boot cast. Flexion of the hip and knee at 90 degrees with traction ropes and pulleys at the pin site and the boot cast. So for nursing care, we're going to do pin care and assessment. We're going to assess the pull, assist with position changes, and toileting. We as nurses never release the 90-90 traction. Okay, remember that, because this is a skeletal traction. It's not just skin, it's skeletal. So only the physician or physical therapy, whoever is responsible for that traction, is the one who will release it for any reason, okay? Because the alignment is keeping the bone where it needs to be. We don't want to misalign that bone.
Whether they need to go to the bathroom, or they need to call whoever to be able to pick it up.
Nope, they're probably going to use a bedpan or a urinal, okay? Because that bone cannot be misaligned. It has to stay in that position.
So if they were to code, would you still keep the leg up?
Probably initially until, because we're going to worry more about the heart beating and breath, and then, eventually we would probably pull it down. But that's not our main goal at that time is, first we want to start at the heart, but then, yeah, you probably will so you can better resuscitate. But in any other circumstance, unless they're coding, the nurse does not touch the 90-90.
Are they always gonna lay flat like that?
No, they can do semi-fowlers as long as it doesn't change the position of the bone. So they don't have to be completely flat in any of these tractions, just as long as that lower leg maintains the position. You're not going to raise on now this one, the lower part of the bed could potentially be raised, just depending on if it, as long as it doesn't mess up the traction. Bucks traction, you have to be careful, and wrestle traction with like lowering the bottom part of the bed. Okay, but the upper part you can go up and down. Of course, you're not going to get them on high fallers because think about that, that's going to extend that leg a little bit more. But semi-fallers usually fine. Cervical traction. Okay, this is those halo rings. Has anybody ever seen somebody with a halo in real life? I have. I had a kid in high school that had a car wreck, and he had to wear it for almost his whole senior year of high school. So the halo ring is used for cervical spine injuries to reduce fracture and dislocation. You may have the ring or the vest. So you can see this little boy has the vest on. The little girl has the ring. Okay, so it's on a pulley system like this one down here. You can see the string going up. Okay, where it's holding her head up. So the spring-loaded is called the Garner-Wells tong. So the head is hyper extended and the neck muscle fatigue, allowing the vertebrae to pull apart to relieve cord pressure. So you have the halo vest, the halo ring, and then she has the pulley system, but then that's with them laying down. So remember, with all tractions, we're going to assess for ischemia, our 7 Ps, assess pain, assess capillary refill, assess temp, color, pulses, okay? Remember the 7 Ps. You're going to assess the neurovascular status, usually right after casting and surgery pretty often, but then every 4 hours after that. Within that first 2-hour period, it's usually every 15 minutes. After that, it's every 4 hours. So now we're going to talk about developmental dysplasia of the hip. Okay. This is a congenital defect. It's also found on page 1521 in your book. So the femoral head and the cerebellum are improperly aligned. Okay. It causes hip instability or displacement, subluxation, so partial dislocation, and an abnormal cellular or structural development, which leads to instability. So that's the dysplasia. 1 in 100 newborns have hip instability. So the pathophysiology, it can be genetic, or it can be an unknown cause, or it can be mechanical, like reach position, oligohydramnios, or fetal size. The left hip is typically more involved than the right due to the intrauterine positioning of the left side of the fetus against the mother's sacrum. Exposure to maternal estrogen can cause laxity of the hip joint, causing instability. So signs and symptoms you're going to see are short femurs, uneven gluteal folds, knee lower on one side, limited abduction on one side, ortolani click. That's the ortolani maneuver, and we're going to watch a little video that shows you how to do it. And visible perineum with extended legs. So on page 1522 of your book, it gives you some actual pictures that you can see. So when the legs are extended, think about the hips are displaced out of place, and you can actually see, like on a female, you can see the opening of the vaginal, the labia. Yes. So this little cute baby butt on page 1522, you can see those folds. See the fold up top, and then the fold down on the side. Okay. So that's significant because that tissue is folding in because that bone is out. Okay, so think about if you've ever seen a normal baby lay on its tummy, you don't see those folds in above the hip. Okay. So the ortolani maneuver. Quick little video. So what happens there, when you saw how the abduct and then close it back, if you hear a click or feel a click or a clunk, then that hip's going back into location. So it's dislocated, basically. Okay? No, because it's been out. Most of these babies have had their hips out of place in utero the whole time. Okay?
How was it in the beginning? Was it extended?
So yeah, you're gonna basically have the baby in front of you. You're gonna bend the knees, kind of push down, and then you're gonna move the knees out. And you'll see most nurses do it at the same time, do both sides. They'll kind of take the knees up in their hands like this. They'll push down a little bit and take the knees back and forth. Okay? And what that does is that moves those hip joints, and you can hear a click or a clunk or feel it when you do that. If you feel a click or hear it, you have to let the pediatrician know, because then they need to have an x-ray done. Okay.
In like babies or?
No, this is just something that happens with babies. Okay. So, degree of DDH. So we have the acetabular dysplasia. So this is the mildest form. The femoral head remains in the incebellum. Okay. The subluxation, that's the largest percentage. You're going to see more babies have this. This is an incomplete dislocation. So the head remains intact with the incebellum, but it's partially displaced, or you're going to have a full dislocation. So the head loses contact with the actual joint itself. So you have 3 degrees. So treatment for hip dysplasia. See that little cute baby? So a longer delay in treatment, the more severe the deformity. So usually these babies are going to have their Pavlok harness before they go home. Okay, they're going to either be casted or they're going to have the harness to wear from the hospital home. You're going to begin that care as soon as recognized. So that's why when we assess the newborn right after delivery, you're going to see the nurse do that within that first hour to 2 hours when they do that full assessment on that baby. Because the sooner we catch it, the quicker we can get that harness on and help reduce further deformity. It varies with age and extent of the DDH. So if it's not caught and it does carry on to childhood, it can get worse. Okay. The goal is to obtain and maintain safe, congruent position of that hip joint. So newborns to 6 months are usually going to have splinting for 6 to 12 weeks until the hip is stable using a Pavlik harness, or they may also use casting. But the most common is the harness, okay? Because then mom can remove it for bathing, things like that. But majority of the day, they're going to, at night, they keep that harness on. 6 to 24 months, if it hasn't been caught or it's not working, the harness, they may have to do surgical close reduction. The spica cast, which we saw where it has the opening for the genital, for 12 weeks, and they may need open reduction if it remains unstable. Older children, it's more difficult because their bones they've started to kind of settle in their position. They're going to do pre-op traction and then do a surgical reduction. So the nursing management for DDH, so we're going to do assessment at delivery, pretty quick after delivery. We're going to have to educate mom on how to use that Pavlik harness and the maintenance of it. We're going to have to teach her skin care. We don't want the harness right up against baby skin, so they need to wear like an undershirt. You're going to assess skinness for redness or rubbing. You want to massage the skin to help with blood flow. You want to put the diaper under the strap so that urine doesn't get on the tracks, because then they're going to have to get a new one, or they're going to cause skin irritation. And then also encourage bonding, because it's going to be scary for mom and baby, right? Because, well, baby's not going to care. They're newborns. They just eat, pee, poop, and sleep. But if mom's going to be like, oh my gosh, can I touch the baby? That's when you encourage, yes. You educate her on how to pick baby up, how to hold baby, how to place baby in the car seat, because it's going to have to wear the harness in the car seat. Okay? So education is a big part of this. So now we're going to talk about club foot. So club foot is found on page 15, 17. There's some really good pictures. So 15, 17 is where it starts. And then if you look over on 15, 19, it has a pathophysiology illustrated of the club foot. Okay. So it's a complex deformity of the ankle and the foot. It's described according to position. So you're going to have your talipes varus, inversion or bending inward, talipes valgus, which is eversion or bending outward, talipes equinus, which is the plantar flexion, toes are lower than heel. So the toes are lower than the heel. The talipes calcaneus, which is dorsiflexion, toes are higher than the heel. And the talipes equinovarus, which is toes lower than the heel and facing inward. So that's the most frequent type. So if you look over at the very beginning of the chapter on page 15, 15, it gives you those different positions of the varus and the valgus. And then on page 15, 21, it talks kind of a little bit about more about the care of the baby. So most cases are a combo of positions, so they can have different flexions that they have, may be isolated with other abnormalities. Okay, so if you have a baby born and you immediately see a club foot, that baby needs to be further assessed for possible other abnormalities. Okay, your most common is going to be spina bifida or cerebral palsy. Okay. Okay, let's take a 15-minute break. We'll be back at 11.
My coworker.
it makes your it makes
Set it up to next year for the 8th. I need to go No, I didn't go. And I'm like, I get paid for this. I don't get paid for this. Like, all off.
Monica, Lisa, Lisa, you have a guest. We're not a guest, it's your brother.
Oh my gosh, somebody heard. All right. I have one. Yeah, I have the same birthday as me. I didn't know her, but
I'm gonna put it on Snap.
I just considered a bunch of them right now. A lot of them are on leave at the moment.
I'm thinking now.
I like.
We only saw him last year. Pictures on the internet? Yes, Ritter.
Other
Man?
that was.
He was like in, yeah. I don't know what they did in the car. And he drove away. They fucking like high speed chased him and they shot and killed him.
Don't kid.
Yeah. Shot and killed him. Mineola? But he literally did nothing.
Hey, there's no more of the ones you got.
Yeah, right.
I don't know which one you got. Did it get ready? Wow.
Natural Valley, right?
Well, it all happened.
¿El lugar tiene moneda de atención? Wait a minute.
Ayer me dieron, me ofrecí el agua con el
Restaurant.
Wasn't there more counting chairs in the thing?
They were on the same.
Very nice.
I'm pretty sure there was Fort County that went with them. That was chasing that guy too.
I'll step on you. Never been to one.
Me la voy a llevar a las carreras porque va a estar Karim León. Por eso me voy a ir también.
Name 3. Another meeting. My life
They call me again and again. My dad has an appointment and he's like almost 16. He's
I got
so
it.
confused.
It's okay. I know it's better to have 2 ears listening than
Yeah, I called him. I'm like, just call me, please.
Well, it's kind of like, my brother-in-law had a melanoma on his backside. And so my sister's a nurse and he went to the dermatologist and he comes back and tells my sister, oh my gosh, I have a 5-centimeter melanoma on my left buttock. And I'm, 5 centimeters, and my sister's like, where? I remember seeing a little spot. So then she gets home and he's like, well, maybe they said 5 millimeters.
Oh.
So it's 5 millimeters. Well, then whenever they went in to remove it, of course, he's talking about how big and deep the incision was because the dermatologist said they were going to have to try to get the margins, because they want to make sure the margins are clear. So he was like, and he went by himself because it's just local. So he's like, oh my gosh, it's really long and deep and it hurts so bad. It's like that big. So yeah, sometimes it's better to have 2 ears listening when the doctor tells people stuff than 1. Okay, continuing on with treatment of the club foot. So this is going to begin immediately, pretty quick after delivery, within 6 to 10 weeks. And what they're going to do is weekly manipulation with long leg casting. Okay, so they're slowly moving that ankle back to where it's supposed to be. So once a diagnosis has been made, treatment is ideally initiated in the newborn period. And there's 3 stages. You have correction of the deformity, maintenance of the correction until normal muscle balance is regained, and follow-up observation to avert possible recurrence of the deformity. So that serial casting occurs. Once it's moved into place, they're probably going to wear a brace for a while, several years sometimes, to maintain that position. And then they're going to have follow-up visits after they're out of the brace to continue to make sure it's not curving back in. So weekly gentle manipulation and stretching of the foot along with placement of that long serial casting allow for gradual repositioning of the foot. So what are we going to assess? Skin, the 7 P's, Babinski, that's a reflex, so we want to make sure they have it. But the 7 P's, your ischemia, your pain, your pallor, your temperature, okay? Pulselessness, is there tingling? You're going to assess those 7 P's every time you have someone that has a casting or even an ACE wrap, okay? Because you want to make sure it's not cutting off too much circulation. You're also going to educate the parents on how to care for that cast with the newborn. So now I'm going to talk about leg cavity Perthes disease, okay? So, or known as Perthes disease, it's on page 1523 in your book. It's a self-limiting condition where there is an avascular necrosis of the femoral head. So what does avascular mean? So without flow, right? Without blood flow. A means without, okay? So without blood flow, basically. So avascular necrosis of the femoral head. So this occurs between ages 2 to 12 and is more commonly found in boys. Can be unilateral or bilateral, so it can be on one side or both. So the pathophysiology, so you have necrosis that occurs from an interruption of the blood supply to the femoral epiphysis from an unknown cause, okay? It could be from a coagulation system disorder, could be caused by trauma. A lot of times you don't know it's occurring. So the disease process has 4 distinct stages over a period of 1 to 4 years. So you have the necrotic stage, so the avascular stage, they're usually asymptomatic. Nothing's different to them. They can't tell that the blood flow has been cut off to that part of the bone. That lasts about 3 to 6 months. Then you have revascularization, which is 1 to 4 years, so you have pain and limited movement. X-ray shows new bone deposits. Fracture of the femoral head can occur. You're going to have bone healing, which is reossification takes place and the pain decreases. And then remodeling. The disease process is over and the pain is absent. You have improvement and the joint function occurs. So it's going to start improving and they're able to move it better. So clinical manifestations we're going to see. After that avascular period, okay, so that initial period where the blood flow stops, they don't know what's going on, but once that necrosis occurs and the body starts trying to revasculate that blood to flow back through again, they're going to start developing pain. So they're going to have limps on the affected side. So remember, this is the leg, it's the femur. Muscle wasting and weakness, muscle spasms, hip soreness or ache, maybe some stiffness. It may be more pronounced in the morning or end of day. Joint dysfunction, limited range of motion, may or may not be a history of trauma, okay? Sometimes it's just due to a little blood clot that has cut off the blood supply.
You said this happens in the femoral head?
Yes. Yep.
Does it happen in the head of the humerus?
No, it's most common in the femur.
So is there like a difference?
Can occur, but you're going to see it more in the femur, okay? But it can, because this, well, I mean, it just depends if it's a blood clot or trauma. So if you do it to your shoulder, yeah, it could happen to the top of your upper arm. But it's usually the femur. So initially, you're going to have rest and non-weight bearing. Later, they're going to have active motion, so you're going to actually have them work it out. Containment of the head in that joint, the incidentellum. Casts, braces, traction, and surgery may have to be done. Conservative treatment may take 2 to 3 years. And surgery, if they do surgery, may be more effective in about 3 to 4 months. So now we're going to talk about osteogenesis imperfecta. So this is your most common osteoporosis syndrome in children. Found on page 1537 in your book. This is where they have excessive fracture and bone deformity. So if you like to watch documentaries, there's actually several documentaries about little kiddos that have osteogenesis imperfecta. So there are 4 types that you're going to see. Type 1 is the most common. They have fragile bones and potential hearing loss. Why would it be hearing loss? Right, because of those middle ear bones. They can fracture too, okay? Type 2, this involves your ribs and your skeletal upper body. It's extensively involved. Most die in utero or shortly after birth. And this is because it involves this part where your heart and chest are, okay? So type 2 usually do not survive delivery or after delivery. Type 3 is identified during the newborn period or infancy when numerous fractures occur and manifest as loose sclera. The child has a severe bone fragility and kyphosis. Type 4 is characterized by fractures without other symptoms of the disease. Legs are bowed and other structural deformities can occur. The incidence of fracture decreases in puberty. So that's the one that you don't have as many fractures as the other 3 types. This is inherited, and you should seek genetic counseling because it's going to be passed on. So what is our nursing management? So we are going to handle these kiddos with care. These kids are fragile. Sometimes it just takes them moving their head, their arm, their hand, and a bone will break, okay? And they'll know, they'll tell you, oh, I just broke a bone. I really wanted to show you guys the documentary today, but I was like, I'll lecture. So, I mean, it's very sad because they know when it happens. They can feel it, okay? So think about the pain, the constant pain because knowing you have constant fractures at all times. So they have excessive fracture and bone deformity. So we're going to support them with turning, positioning, and moving and holding. Be very gentle. Something as simple as changing the diaper can cause a fraction. So think about when you change a baby's diaper, you usually grab both ankles and hold the legs upright while you're wiping, throw the other diaper in, and then you go, okay? You have to be careful with them. You hold the legs wrong, it could dislocate the hip. Could fracture the ankle, could fracture any part of the leg, okay? Obtain blood pressure using a manual cuff to prevent fracture because you're going to be able to puff up and release quicker than what a machine will. Screen children with history of fractures. Educate. Limitations and planning activities that are suitable for this child. So think of some things. You have a child with osteogenesis imperfecta. Can they play soccer? No. No. No.
But even if it's like type 1?
No. They are too big of a risk to have a fracture. It doesn't take anything for their bone to break. So what kind of activities would you plan for a child? Knitting. So if it's an older kid, teach them how to knit. What about a 5-year-old? Dolls. What else? Coloring. TV, but let's not do TV. How about board games? Because a 5-year-old can do board games. My 5-year-old has this really neat Bluey game, and it's all based on colors and counting. Like they don't have to recognize anything but the shape, color, and counting because that's what she knows, okay? So think of things they can do where they're not having to have a lot of physical activity, okay? They might still be able to play maybe throwing the ball, but with a soft ball, not like a harder plastic, but like a cloth spongy ball, like a Nerf ball, you know? Think of things they could easily do that's not going to cause any more problems. So resources to link this family or your child's family with other families that are dealing with this same problem. Because other families may have created an idea that will help another family, you know? And so if they can kind of work together in a community and exchange ideas, and then also have someone who can support you and knows what it's like to go through a problem like that.
Is that pretty HIPAA?
As long as you give them the information and they contact. You're not doing the contacting. You are just giving them the information for the group. So there's lots of things like in OB, we give them, like if we have a fetal demise, we give them the information for grief support. And then they contact the grief support group and get involved. But as long as you're just giving them the information and not contact. So what are some treatments? Okay. So supportive. So basically just devices to support. So if you have a child that's got, rib fractures or a spine fracture, they're probably going to be in a brace. And we're going to treat the fracture, splints. They might have to have surgical corrections if the fracture is big enough. Braces, maybe even rods placed in those bones to help hold them in place if they've fractured multiple times. We're going to talk about muscular dystrophy. It's a group of inherited diseases where the muscle fibers degenerate and you have muscle wasting. The onset can occur at birth or occur gradually. The most common form in children is Duchenne or pseudo-hypertrophic muscular dystrophy. It is characterized by muscle enlargement due to infiltration with fatty tissue. So on page 1540, it provides other types of muscular dystrophy that you might see. Diagnosis and classification are typically based on clinical signs and patterns of muscle involvement. So what are we going to do as a nurse? We want to promote independency, okay? This is very debilitating, this disease is, and it's kind of like, think of MS. It's over time. Usually they're fine. They've been able to do all these things, and now their ability to walk is decreasing. Their ability to write and use their hands is decreasing. But we want to help promote independence and mobility. Psychosocial support, because if you have a teenager that's been able to do all these things as a child and now they've kind of slowly progressed to where they can't, they're going to be frustrated, upset, mad. They're going to go through all those cycles. Assess urinary function and frequency of bowel movement, because if your muscles are deteriorating, that peristalsis that occurs is going to slow down too. Okay. Measure strength and range of motion. You want to do physical therapy, prevent injury, and health promotion. Scoliosis is another musculoskeletal disorder. We kind of talked about that earlier. So this is that S shape. Okay, this is pretty severe scoliosis. Okay, it's a spinal deformity involving the lateral curvature, spinal rotation, rib symmetry, and thoracic hypokyphosis. So functional scoliosis is caused by some other deformity, so maybe like a short leg, so you have one leg that's shorter than the other, so then you've got, think your curvature of your spine is just because of the offset of your leg, okay? This is most common in females, scoliosis is. How do you assess? So you take a child, so when, if you ever get to go into if you're a school nurse, a lot of times they do the eyes and ear test, but they'll also have them come in and they'll have them bend over, okay? You're looking for the S shape in their back or that kyphosis, which you can see really well on me. I have scoliosis in my back, okay? And it's causing, as time has gone on, has caused me to develop kyphosis. So this can happen, okay? So usually your legs are uneven, hips are uneven. You might have a rib hump. You can see on this kiddo how he has the ribs that hump up on one side. Screening is required in schools, and that's where the school nurse has them come in. They usually do everything at once. They check for headlights, have them bend over, because they're going to look at that spine, okay? They're going to do x-rays of the spine. So what is treatment for these kiddos? The goal is to straighten and realign the vertebrae. So exercises can be performed to strengthen the weak side with checkups every 3 months. Electrical stimulation for the weak side, so you're stimulating those muscles to then grow, help support. Bracing with a Boston brace can be used to maintain existing spinal curvature with no increase. The brace is usually worn 23 hours a day. Compliance is an issue for adolescents, because does anybody want to wear a big bulky brace around when you're a teenager? No, your image is such a big, important thing, right? Gotta have the right hair, the right eyelashes, the right clothes, the right nails, and you add the brace on. You know, so then they're gonna be like, oh no, I'm not wearing that. So then you have a problem. It's gonna increase that curvature again. They may do spinal fusions. Spinal fusions are very painful and limiting. Once they heal, most people do well, but some people don't. So there's hooks, wires, rods, and screws that use a Luque wire to help stabilize the spine. Anti-posterior plastic shell is worn for several months to provide stability for that spine post-surgery. So compliance adolescents, 2 years is not now. They're like, I'm not gonna do it now. I don't want to. I'm on the go, okay? Developmental stages, they have peers that are gonna be influences. They wanna fit in. Independence versus dependency. I'm a teenager, I'm an adult, I can do what I want. So compliance is gonna be a problem. Body image, style, like we talked about. They don't wanna be any different than anyone else. It restricts activities that they can be involved in. So for nursing, we're gonna do assessments. We're gonna perform the spinal assessment to detect the possibility of scoliosis. Educate the child and family on prescribed treatment and success. Pain management, because it can be painful for some. Allow the teen independence, choosing when to exercise and when to be out of the brace during the day. Provide info about fashionable clothing that can be worn with the brace. Teach proper body mechanics and how to do simple tasks without bending or twisting. Surgical patients should be log rolled to ensure alignment of the spine. So if you have a patient who has surgery on any spine or hip, you're going to do the log roll, okay? So that means you're going to put their legs together, arms down to the side, and you're going to roll the whole body at the same time, okay? Because we don't want to misalign that back. Log rolling is important. Osteomyelitis is an infection in the bone. Common in children from 1 to 12. So it's usually a Staph aureus. That's your most common. It can be group B strep in the neonate. So how is it acquired? So what happens is they get an infection, goes to the bloodstream, and then it penetrates through the bone, okay? Can also be by a puncture or a pierce near that bone, and that infection gets close to the bone. Abscess or foreign body can be a reason. Surgical contamination adjacent to the tissue that's infected. Immunosuppression or malnutrition can also be reasons to develop osteomyelitis. When I had my surgery on my toe to fix it, 6 weeks later I developed osteomyelitis, and it was bad. So symptoms are going to be history of infection, pain, tenderness and swelling, decreased mobility of the infected joint, fever, erythema in the site, may refuse to walk or may limp, and it's rapid onset and usually misdiagnosed. Treatment for these kiddos, you're going to have IV antibiotics after the culture and sensitivity is done. Maximum dose to cover the blood-brain barrier. You're going to treat for 4 to 6 weeks. They're going to probably do surgery and drain that area or clean that bone up. You're going to use analgesics for pain. Watch for signs and symptoms of infection. Give them drainage precautions. We want to prevent dehydration because we need the fluid and electrolytes to be normal for healing. A high-calorie diet, which also helps with healing. Protein, vitamin C. You can use ice or heat at the site. You know, have fever management. Immobilize to prevent spread. You don't want that infection to go to other parts of the bone below or above. Home care for antibiotic treatment. And so some complications you might develop is septic arthritis later. So now we're going to talk about juvenile idiopathic arthritis. So unfortunately, kids do develop arthritis as kids, and it's not a common thing people realize. It's kind of taken for growing pains, or, oh, you're fine, or you work out too much, and these kids actually have arthritis. So it's also known as juvenile rheumatoid arthritis. It's a chronic autoimmune disease. It's characterized by remissions and exacerbations, so they can feel better but then get worse overnight. The cause is really unknown. They may have had a previous injury or trauma or infection at that site. Immunoglobulins in the joint become antigenic. Immune factors lodge in the sinusoidal or the synovial fluid of the joint. So you've got those immune factors that get in that joint fluid, which causes inflammation, swelling, and pain. Also limited mobility. So our treatment, what are we going to do? We're going to help reduce pain, maintain mobility, reduce inflammation with NSAIDs, monitor salicylate, or your aspirins. Oral gold salts are another type of treatment. Corticosteroids, low-dose methotrexate therapy can help, physical therapy, or injections at the site. Precaution with your aspirins and NSAIDs. Why? What do they do? Ladder. Okay. Toxicity, but what's another thing? What's a spot that they can sit and cause some irritation? Stomach. Okay. If you take ibuprofen, naproxen, aspirin, it can cause ulcerations in your stomach. You're going to have bloody stools and abdominal pain. Okay. So watch for toxicity when combining with other drugs. Do the corticosteroid precautions. Remember, corticosteroids can cause the immune system to be suppressed. Infections, discontinue medications that suppress the immune system. So your corticosteroids, if you do develop an infection, you're going to have to stop those. Talk about good nutrition, sleep, rest, exercise, appropriate for level of pain, age of child, splinting and positioning during rest, and acute inflammation. Okay, so I know she said yesterday you talked about osteosarcoma, so we're going to skip over that. So if you will just read the bullet points on those, we're not really going to, there's not going to be any test questions over osteosarcoma, okay, because it's a cancer, it's just cancer of the bone, okay? This is something commonly seen in kiddos, okay? So sports injuries, these are the most common injuries in youth. You have foot, ankle injuries, fractures, stress fractures that occur, contusions, dislocations, overuse injuries where they just play one sport after another and they're not allowing that part of the body to rest and relax and heal. You can also have sudden death, acomatio cordis. Happens. You hear of kids playing basketball or football and fall over dead. A lot of times it's due to a cardiac issue they didn't know they had. More risk for injury due to growth plate vulnerability, increased joint mobility, knee, ankle, hip injuries. They have porous bones, so fractures are common. Lack of experience, inadequate training, improper or no use of protective gear. Impatience. Who knows a teenager that's impatient? I have two of them. Spinal injury vulnerability related to high impact sports. So as a nurse, we're going to assess the neurovascular assessment again, our 7 Ps. We're going to educate the importance of warm up and cool down, stretching prior to starting exercise, cooling down at the end, wearing protective equipment. Even if you're just going to go out and play a game of, football on the field on Thanksgiving, if you're not playing flag and you're playing where you're hitting, be careful. My husband's family does it every year, and I'm like, oh, somebody's going to die. You're going to rest any injury for 24 to 48 hours. You're going to ice 20 minutes 4 times a day. You may do compression and elevation. Then you're going to gradually increase the motion to that injured site and gradually return to the sport. Okay, got a few NCLEX questions we'll go over real quick, and then I'll let y'all out of here. A nurse is educating a family about the type of fracture their 8-year-old child has experienced. Which description would be an accurate way to explain a closed fracture of the radius to the family. One of the bones in the arm broke completely and penetrated the skin. One of the bones in the arm broke completely but did not penetrate the skin. One of the bones in the arm is broken incompletely like a green twig, or one of the bones in the arm is crushed and broken incompletely. Two, right, so that one was pretty easy to deduct, right? Because we know a complete fracture where it's separated completely and it's not piercing through the skin. A school nurse was evaluating a child whose leg was hurt in the gym class. The nurse feels it is a muscle strain, but is still going to refer the child to the primary care provider. Which instructions should the child follow until seen by the PCP? Increase motion to the extremity, try to walk on it even if the pain is experienced, go back to gym class and participate, apply ice for 20 minutes at a time. Ice, right? Although I am one of those people, rub some dirt on it and walk it out. My poor kid. Okay, 3, the school nurse is screening the 6th graders for scoliosis. The nurse notes that one of the students has excessive convex curvature of the cervical thoracic spine. This finding would be indicative of which following. Okay, convex curvature of the cervical thoracic spine. What part of the spine is that? Top here, convex kyphosis. So scoliosis is the S shape. Lordosis is where you have that swaying of the back. And torticollis is totally not anything to do with. Kyphosis. So a nurse is caring for a child who has just received a cast. Which of the following considerations would be important in providing care for the child? Assess the casted extremity every 15 to 30 minutes in the first 2 hours after cast application. When handling the cast in the first 24 hours, use fingertips only. Give the child a blunt object to help with itching under the cast. Or apply powder to the inside edges of the cast to help decrease moisture. Okay. Important in providing care. Okay, so some of them are correct, but the one that I would say is the most important is I need to evaluate that the 7 P's within that 15 minutes, every 15 minutes for the first 2 hours. Okay? So it is important to not use fingertips when touching the cast the first 48 hours because you don't want to cause an indentation, remember? So you're going to use a whole hand. Lotions and powders should not be used near the cast because then that's going to be a breeding ground for bacteria and cause skin irritation. It is important to assess extremity of the cast and then for intact circulation and sensation for the first 15 to 30 minutes, and you should never put anything in the cast, okay? Last one, the nurse closely monitors the child with a long leg cast. After femur fracture from compartment syndrome, which of the following would the nurse include in the assessment? Okay, 7 P's, so is the first one paruresis? Okay. Paresthesia? Yes. Piloerection? No. Poikilothermia?
Yes.
Yes, remember that's the pulling in the air. Pressure?
Yes.
Yes. Pulselessness?
Yes.
Okay, good job. There you go. Okay, I hope so. That's my goal.